Hi, and thank you so much for tuning in or sitting to watch the first SCCP Collaborative Journal Club event. Today, Cedarville's hosting. This is being streamed on YouTube, but there's a pretty strong delay for those of you who are watching. So when it comes time for questions and things, just know that it is a little bit behind. So I'm just going to do a quick introduction of the topic for this evening. So since it's February, it's American Heart Month, it's also the month of Valentine's Day. So we chose cardiovascular pharmacology for our topic, and we're going to present an article regarding safety monitoring of dofetilide or Tikecin, which is an antiarrhythmic agent. And so we're going to talk about the REMS program and some changes that have happened to that as recently as spring of last year. So I'd just like to introduce our presenters. First, I'm Jessica Ward. I'm president of Cedarville's chapter of SCCP. And then next is Neil Fox. He is going to be starting his APPEs this spring. So he's final year in his class studies, and he's going to be our core presenter. And then our final presenter is Sarah Berman. She's class of 2020, and she's going to be kicking us off, giving some background about the drug.
All right, well, welcome everybody. We're really excited that you came or that you tuned in tonight. So the study that our org chose was over the drug dofetilide, also known by the brand name of Tikecin. It's a class 3 antiarrhythmic drug, meaning that it works by blocking inward rectifier potassium channels. This will prolong phase 3, but it is a little unique in the realm of cardiology and being a pure class 3, meaning that it has no effect on sodium channels and adrenoreceptors at clinical concentrations. So it's only affecting those inward rectifier potassium channels. It's indicated for conversion of atrial fibrillation and atrial flutter, and after that, the maintenance of normal sinus rhythm, so keeping these patients at a good rhythm. It also causes, on the negative side of things, it causes an increase in QT prolongation, and it also increases the risk of ventricular arrhythmias, namely torsades, which is the main consideration in the first week or so that they are starting on it, because that's our big concern at the beginning. Because of this, we like to monitor the creatinine clearance and electrolytes, which is very important in those first couple days to make sure that it remains at a therapeutic concentration. In light of this, in the beginning stages of this drug, the FDA implemented a REMS program in 2001. For those of you that don't know, REMS stands for Risk and Evaluation Mitigation Strategy. So it's a kind of a way to make sure that the drug is being monitored in correct ways that will help reduce those adverse events. In this case, it required that dofetilide was only prescribed by certified prescribers through Pfizer, and this could only be in certified hospitals and facilities. And these facilities had to provide extensive education to the prescribers so that they would know the risk to the patients and what needed to be done to try to minimize these risks. In 2016, FDA decided to discontinue this program based on the fact that it had been seen that prescribers seemed to be very aware of the risks, and these different guidelines that they were providing, all the education, had been worked into the clinical practice guidelines, so they didn't feel like the very strict prescribing was necessary anymore. Additionally, there are other drugs that are similar that actually have the same or worse risks that weren't exposed to the same amount of regulation. However, the drug still requires inpatient initiation, so when a patient is started on this drug, they have to be in the hospital for at least 3 days to watch for that torsades. We would monitor creatinine clearance as well as their electrolytes. They'd be on continuous EKG monitoring, and we're also want to be there in case cardiac resuscitation is needed. And with that, I will pass it off to Jessica.
So I'm just going to kind of set the stage for the article that we dissected for the Journal Club by telling you guys about some recent studies that have come out. So some of the highlights of the data that's been gathered around dofetilide regarding risks for mortality, female gender, advanced age, heart failure, and then increasing dose are related with increased risk of mortality. As Sarah said, the TDP, the torsades, is dose dependent, which is a little bit kind of special to dofetilide. Also, TDP events that occur within those first 72 hours of initiation, which is done in the inpatient setting, were linked to a higher risk of all-cause mortality a year out if treatment was continued. And then kind of interestingly, that risk of all-cause mortality levels out between patients that were treated with dofetilide and patients that just received a placebo or were in the control group. So kind of your major risk period with the antiarrhythmic agent is in that first year of continued use. So some deficiencies of the data or some low points of what we surveyed was that all the data was gathered retrospectively and relied on patient charts and EMRs, which for any of you who have any experience know that those aren't always perfect. So that's kind of an issue with that. All the studies were done at single institutions only, so that means they had very small Ns. And then the EMERALD trial, which was a core trial used in the FDA approval of dofetilide, was powered only for efficacy and not for safety. So that's kind of just a note. The FDA approval ultimately rested on a meta-analysis of pooled data instead of kind of those standard RCTs that you see with a lot of drugs. And then the drug that I saw dofetilide compared most to in these studies was sotalol, which they're not exactly the same. They have a little bit different mechanisms. Sotalol works in several ways. When that drug produced its atrial fibrillation indicated formulation, beta-base AF, it wasn't subject to REMS and wasn't subject to a lot of the same regulations that dofetilide was. So some of the information that we have, the experience that we have looking back at it, the data is not as well controlled because it wasn't subject to those regulations. So that one-to-one comparison that kind of powered these is really kind of flawed and impossible to establish.
All right, so as the ladies established the background for you, dofetilide is a useful but potentially very dangerous drug that's subject to a significant amount of monitoring in order to ensure best use. So this study was performed in Gainesville, Florida at a Veterans Health Administration facility, just a single center retrospective cohort study. And their objective was to assess if utilizing a combined service of pharmacy and cardiology that was specifically focused on antiarrhythmic drug monitoring, if that program could increase compliance with the necessary REMS required monitoring. And their problem statement, or at least one that we can pull from what they've said, is that because dofetilide is such a dangerous drug, it's important to have optimal monitoring. And this service, they were hoping, would improve that monitoring. They hypothesized that, indeed, the program would increase the monitoring, and they created a pharmacy-directed service with cardiology oversight to improve patient safety, medication compliance, and access to care. So they reviewed patient medical records to determine if each of the 4 primary monitoring parameters, serum potassium, serum magnesium, kidney function, and EKG, had been obtained within 1 month before or after every 3 months. The patient is expected to have all 3 of these recorded every 3 months, and if it was done within 1 month of those time points, it was counted as complete. They originally looked at 87 patients, only 30 met the inclusion criteria. 97% of their patients were male and the mean age was 65, which they later explained is consistent with the fact that they're a Veterans Health Administration facility. Their inclusion criteria were that the patients had to be 18 years or older, they had to have been taking dofetilide consecutively for more than 3 months, and they had to be referred to the service in question. They did not include any patients for whom all the monitoring of dofetilide was completed through the pharmacy cardiology service. So the 2 groups that they used for their stats were the same patients before and after entering into this pharmacy cardiology combined service. So in light of that, there's no randomization done, and the enrollment of eligible patients in the pharmacy cardiology AAD monitoring program, where pharmacists ordered, reviewed, and interpreted monitoring, that was the intervention. Their primary outcome was a composite looking at instances of collection of monitoring parameters, looking at all four, how many times it was missed, how many times it was gathered, and then secondary outcomes, they looked at each individual monitoring parameter to see whether or not the compliance with the REMS improved. All statistical analysis were performed using the Fisher's exact test, which is appropriate for small numbers of binary data, which this is. They set their alpha level at 0.5, but they did not discuss any type of sample size or power analysis. So the results. Compliance with the composite endpoint of all the monitoring for dofetilide increased from 69.6% prior to entry into the pharmacy cardiology monitoring program to 98.5%, not 985%, that would be very impressive, to 98.5% after patients entered the intervention. Here you can see the increases for each of the individual monitoring parameters. EKG monitoring increased from 71.6% to 100%. Serum potassium monitoring increased from 75% to 100%. Magnesium, 56.8 to 94.1. And serum creatinine from 75 to 100%. And all of these differences were also statistically significant. So if we run the numbers, the relative risk reduction of a patient missing any of these monitoring parameters after entering into the program was 95%. They were 95% less likely to miss any one of their monitoring parameters after entering into the program. Now, the patient or the author's interpretation of their own data. They admitted that it's quite difficult to conclusively say that this intervention caused the improvement or that similar results would occur elsewhere. One thing they pointed out was the fact that pharmacists at this facility, being a VA facility, had the authority to prescribe and order and do things beyond the scope of practice that other pharmacists at other facilities might have. And so these results may not be replicated elsewhere for that reason. It's also difficult to know whether such an improvement is necessary, because if your site already has really good compliance with dofetilide monitoring, you don't necessarily need to create an entire service for that purpose. They were very honest with looking at their own limitations, which is always a good thing. Whenever you do data, nothing ever goes perfectly, and you should always be honest about the difficulties in your study, because that only helps people interpret your results better. So they said that they did not actually assess patient safety, which is probably the most critical thing here. The point of increasing monitoring is to improve patient safety, but they didn't look at any patient outcomes, and they didn't look at incidences of torsades or anything like that. And so while the numbers look really good, it's really hard to say whether or not they truly mean anything, whether they're clinically significant. One thing they pointed out was that the length of time patients were in the pharmacy cardiology, the combined monitoring program, was shorter overall than the length of time that they were outside of it. And so it's possible that the improvements may have dropped off after that. And then they admitted that their study likely has low generalizability due to a small sample size and it only being at one site. But they did conclude that the intervention improved compliance with recommended dofetilide monitoring, and that this may be even more important in the future, because as we saw at the beginning, the FDA has actually taken away the REMS program since the end of this study. However, what this could mean is that in the future, we'll have a lot more prescribers and a lot more pharmacists dealing with this drug who are not familiar with it. The monitoring is still required by the guidelines for atrial fibrillation, and the package insert still requires patients to be in hospital for 3 days after the initiation of this drug. So it's not that the monitoring parameters have actually become less stringent, but they've taken away the requirement for everyone who uses this drug to be extensively trained on it. So in the future, we'll have people with a lot less experience and specific training dealing with dofetilide. So overall, the strength of this study, it's a unique topic that hasn't been studied before. There aren't many studies out there that I found or that the authors found looking at compliance with dofetilide monitoring. And it exposes a gap in patient care that pharmacists are well suited to fill. We should be the ones who are very familiar with the required monitoring for all of our medications, especially ones with as potentially serious side effects as dofetilide. And so there's an opportunity here for pharmacists to step in and help improve required monitoring with drugs such as antiarrhythmics. And I thought it was a strength that the authors recognized the study, the limitations of their own study. Now, as they said, small sample size, that's going to be a weakness. And one weakness, it's kind of not surprising, their results. And let's be honest, you created a service specifically to do something, and that service did it better than when there wasn't a service specifically to do that thing. So when we look at these study results and we think about the research that we're running now as pharmacy students or that we're going to run as residents, you have to think about making research that's really significant and impactful, but also this is the type of thing that you do every day, maybe not even to be published, but to justify positions, to justify FTEs. And so sometimes even what seems unsurprising can be significant once you actually record it and put it down and you can put those numbers in front of people. The reproducibility of the study is low, very specific site with unique abilities for pharmacists, unique scope of practice. But as we stated earlier, dofetilide use may become more common now with the removal of the FDA REMS program. And so finding patients who need the drug and need appropriate monitoring may become easier in the future. So in the future, when we're looking to expand pharmacy services and close gaps in care, this is the type of research that we need to start with. However, as the authors recognized, and I think we all do too, it's very important to also collect data that shows clinical significance, that shows that you're actually improving patient outcomes. Because from one perspective, increasing monitoring just means increasing costs. So you have to prove, you have to show that what you're doing is cost effective. Are you reducing hospitalizations? Are you reducing instances of cardiac resuscitation? And so it's important for us to look at studies like this and think about the research that we're going to do and evaluate in the future in light of the design to show the clinical significance and perhaps even the cost benefit of interventions such as this. So now we'll open the floor for questions. Okay.
One thing that really stuck out to me is like since we discussed how the REMS program is now discontinued, given that this was seeing how it helped REMS compliance, where do you see like the place of pharmacists? How do they implement this study now? But given that the justification of it was, well, we need to do this for REMS, but now REMS isn't there.
Yeah. So the question was, again, what's the significance of the study now that there's no longer a REMS? So there's two parts to that. The monitoring for dofetilide is still very important and is still required. What taking away the REMS has done has opened up the options for dofetilide use to prescribers, to pharmacies, to facilities that now do not have specialized training in the risks and required monitoring for dofetilide. So it's conceivable that dofetilide use will become more common now that that barrier of the REMS is no longer in place. And because the monitoring is still there, pharmacists should be aware of that monitoring. It's still very necessary. We can use this study not to justify increased REMS compliance, but just to justify increased monitoring compliance, and hopefully that leads to clinically significant outcomes such as decreased hospitalizations and decreased incidences of torsade.
I didn't really get a chance to go through all of the studies, but can you kind of speak to the dofetilide's place in therapy compared to other like class 3 antiarrhythmics?
Yeah. So dofetilide is one of the first line agents for rhythm control in atrial fibrillation. You'll remember that within atrial fibrillation, you have the option between rate control and rhythm control. Usually you do rhythm control if patients are still quite symptomatic, even despite adequate rate control. You're keeping their heart rate down, but they're still really symptomatic from their AFib. And so especially in patients who have CAD or no structural heart disease, dofetilide is one of the recommended agents. There's an option. There are options for every category, but dofetilide can especially be used in those patients for rhythm control. And rhythm control is converting patients back into sinus rhythm and keeping them there. All right, so there's a question from Neomed. It says, is there a protocol for what the pharmacist did if they found a problem during their follow-up appointments? So they don't talk much about that. In the study, they mentioned that twice they found significant drug interactions with dofetilide, and there are several, because dofetilide's efficacy and its QT prolongation are directly dose dependent. So the higher the serum concentration, the more you extend the QT, the more likely you are to cause torsade or some type of arrhythmia. So there are several drug interactions that are very significant, specifically ones that decrease the renal excretion of the drug and therefore increase plasma concentration. So to answer your question, no, there wasn't anything mentioned in the study about how pharmacists resolved issues, but they did mention that there were some minor interventions that they didn't track or do any type of stats on. So there's another question from Toledo. It says, if monitoring was done within 1 month before or after the ideal date, it was considered appropriate. Do you feel that this is an accurate range of time if patients should be seen every 3 months? I think that's a really legitimate question because there's no other studies to compare it to. It's hard to know what is considered valid as far as that go. They didn't explain why they chose a 1 month window, because yeah, you can think of if someone's 1 month late on one monitoring date and then they're a month early on the next one, and then they're a month late on the next one, now they've gone quite a few months before they've been seen. I think that is an excellent question for future research once we figure out some clinically significant outcomes related to monitoring research, to look at shrinking that window for allowing what we consider to be appropriate and then seeing if the outcomes actually change. I think that's a very reasonable question. So we have another question from Toledo. How do you feel that this study could be modified to better show a clinical impact from the improved monitoring rather than simply showing that monitoring was improved? So it's retrospective. There's certainly a possibility for going back into the charts and trying to find clinical outcomes. Now, honestly, besides Torsade, dofetilide is quite an innocuous drug. It really doesn't cause that many side effects. And that risk is primarily associated with the first few days within initiation. So it's hard to say how frequently those instances would occur, even with poor monitoring. And so it's hard to say how long you would actually have to follow patients or how far back you would have to go to see an incidence of Torsade in the middle of therapy because of poor monitoring of things like serum creatinine or potassium. Now, this same type of model applied to other drugs might be more important because there's an increased risk of side effects outside of that window of initiation.
This might be somewhat outside the scope of the study, but do you know how long patients are usually hospitalized after the diagnosis? Like, is that 3 days of staying in with the dofetilide prohibited, or they are going to be in the hospital anyways at that time? That actually 3 days monitoring.
No, I mean, they're not, you don't normally have to be, depending on what, so along with atrial fibrillation, of course, we're thinking about anticoagulation and whatnot. So depending on which anticoagulants you start and how long you need to take for them to get to therapeutic, my understanding is that patients are not normally in the hospital for this long unless they're started on dofetilide. So that still is going to be a barrier to its use out in practice. Although I think it's relatively high safety profile compared to other antiarrhythmics, could be something that prescribers find attractive now that they don't have to go get a bunch of extra training just to consider it as an option.
How would you think, like, cost of extra 3 days would play in above just the drug cost itself?
Yeah, I mean, that's definitely going to be really significant, especially when you think about what level of care these patients are in. Now, if all they need is continuous EKG monitoring and some blood draws and whatnot, it's not like we're talking about 3 days in the ICU, but we are still talking about taking up a bed, and that's quite significant. So you always have to consider those extraneous costs outside of just the cost of the drug itself when you're doing any type of cost analysis.
There's another question from you.
Oh. Do you think that reproducing the study or something similar to it under the Ohio Collaborative Practice Agreement is feasible? Yeah, it definitely is. Now in Ohio specifically, we have the option to expand our scope of practice as we work with physicians. And so while the results may not be as reproducible in non-VA facilities in states that do not have collaborative practice agreements, here in Ohio, there's definitely an option to allow the type of pharmacy independence that we see here, just as long as you have a good relationship with the people that you're working with.
Ooh, I have a question.
Okay.
Do you think it would be possible, kind of piggybacking off of the kind of cost impact, do you think it would be feasible to do this outpatient if you're, like what you were saying, mostly worried about electrolytes or EKG? If like the risk is not so high, could they have more irregular EKGs instead of like the continuous monitoring?
So they have to have that continuous monitoring for those first 3 days, right, because the risk is so high. I really don't think you're going to get around that because we've seen that all the way back into the studies that were used to approve dofetilide, that the risk for Torsade is much higher early on. They have to get I mean, when they come back in the 3-month intervals and they're getting their EKG checked, it's just a quick calculating the QTC and moving on. That's my understanding anyway. I don't think they have to come in and stay for like a day and get extended continuous EKG monitoring. All right, so we're really excited and thankful that everyone came here. I know you're all glad that we didn't take up nearly as much of your time as we thought. Don't leave just yet, because we'd appreciate your guys' feedback. What we're hoping these events will become in the future is that we'll actually have like a traveling journal club where every semester we'll have one of these events, and we'll get the different schools from around Ohio to present to one another, so that we as students can meet one another, we can share information, and younger students can practice doing journal clubs, older students can practice doing journal clubs, because we all need practice doing journal clubs before APPEs and whatnot. And so we're really excited about the potential in the future to constantly breed collaboration between the different schools of pharmacy, specifically the SCCP chapters, but really, this opportunity is not just about us. It's about sharing knowledge and building relationships that, especially if you stay here in Ohio, are likely to continue throughout your practice. So I'll hand the floor over to Jessica, and she can tell you all what she wants you to do.
Okay. So I guess this kind of feedback portion is just kind of your guys' opinion on the value of this sort of initiative, whether you'd be willing to participate in future iterations of it, and then also what your thoughts are on the timing of it. When we initially had discussed this, we talked about having 2 schools working together to present 2 articles on a similar topic per session. And I know that our article is a little bit shorter, but we've completed everything in 35 minutes. So in my mind, it would be feasible to do 2. But this is just kind of open feedback for you guys on this event, the value that you think it has, and then any suggestions for improvement going forward. So the floor is open. Yes.
I appreciated it. The elective that I'm in, we have to do a journal club soon. And so she was like, yeah, if you guys done journal club, we're all so, not really knowing what I'm doing. I mean, we've done, a lot of GI projects and stuff by now, but it was nice to just kind of like read it out.
I try to build this based off of the rubric that we have for capstone. So hopefully for you guys, it'll be something that's directly relevant to you. I'm interested to see when we do get other schools what their handouts and rubrics and expectations are, because it could be very different. I know that even here we've seen some slight differences in the way that journal clubs are done, but yeah, so hopefully that will be beneficial.
So there's a question from Neomed. Laura's asking, would it be possible to use Google Hangout or something to allow video chatting? That is a potential option. I think we were concerned with feedback delay in trying to get that much bandwidth, but it's definitely something that we could try in the future for sure. Okay, I have a legitimate question. Would you guys come to this if there wasn't extra credit? And like, I'm serious. I like 100% honesty. Would you come if there wasn't extra credit? Okay, so we'll keep extra credit in mind. Yes, Caleb.
I think that I would be more inclined to come if you guys were doing 2 articles on like a similar subject, but maybe counter arguments, because then I would be able to see like 2 sides of the same coin, which to me would be a better, I guess, learning experience and be more valuable for me personally.
Okay, so talking about advancing clinical reasoning by presenting you two sides
Mhm.
and giving you the tools to kind of reason through that.
Yes.
I like that. That's very good. Anybody else have? Yes.
Something too for future, maybe relating it to something we're currently doing. And the teachers who already have cardio and teachers have at this point too, but maybe just, like one of the modules that we're doing, picking a drug or a study that goes along with what we're currently learning.
And that's definitely something we could do from our end. But as far as the other schools, they're on different schedules, so it's not always going to be. Yeah, that's true. I guess on the upside, like it will jog your memory if you've already covered it.
I think coming from like a P1 standpoint, this was really, really stretching for me, but it was really rewarding. And I feel like I have a lot better understanding of like how to kind of go through an article. I feel like we talked about it a lot in research and we talked about it a lot in DI, although not that far into DI. But it was really helpful to be like, okay, this is where you go. Like I went to package insert and found what I needed. And it was interesting to come from something that I knew zero about and then have to like be able to talk about it. So it was, I think, a really good growth. The Neomed is saying that they
can't hear us.
So
Testing. Neomed, is that better? A little bit?
Probably just keep people asking questions.
Yeah, so I was
Okay,
thinking like
I'm
passing it
loud
around.
anyway. Does anybody else have a question so we can test it further? Someone in the back.
Turn the thing all the way around.
It should be on. Is there like the hand for it?
So
For this one, we intentionally picked a shorter article because we know that you're not going to read it ahead of time. So we wanted to at least have one that you could look over if you wanted to on your computers. We did send out both the article and the handout to everybody in email form, I believe. So that option, that should be something that will continue every time. We'll make sure we get the right documents to you so that you can follow along. Because I know this isn't, having it up here on the screen for us Cedarville people, is, I know you can't really read that, but maybe like you guys in the first row can. So we did pick a shorter article this time, partly for time, so that you guys could reasonably look through it. And this one didn't have a lot of stats, which is always the bane of everyone doing any type of journal club, is when they start throwing out, Cochrane, Hansel, Meinzel test, and you're like, what? Yep. Yeah, that is a real thing. I probably mispronounced it, but.
Okay, so for now, we're done. I just wanted to take a couple of minutes and say a big thank you to Neil for putting this together and Sarah for helping. And then also thanks to all the other chapters for being so supportive of this and tuning in to watch. And then Andrea Pilata as well from SCCP, who helped a lot with getting the logistics together to do this. So at this point, we'll end the live stream. And then for the other chapters, there will be an evaluation that you can fill out after this that you can send back to me. Okay, well, thanks for watching.